Okay, we're going to be discussing when they get what they can. So I'm going to get the list of the patient that I have. Okay, did you get the latest information regarding the HLR, Mr. Guru?
Guru, can you unmute yourself? So did you, do you mean Dr. Azadeen about HLA typing?
Yes, yes, because it was confused. They didn't put the name of the patient.
So we got the HLA typing of the last kid which you had sent.
Yes.
With the boy with sickle cell. Yeah.
Yes.
So whatever family members are there, they are not a match. I went through that today.
Okay.
They are not a match.
All right. So do you think?
So if we have, do we have any specific agenda? Otherwise, I just wanted to brief you about how it works. So is that okay?
Yeah. Go ahead.
All right. So Guru and Prabhat, is that okay? I just wanted to brief Dr.
Sure, sir.
Yeah. All right.
Sure, sir. Okay.
So see, we, as I said before, we look after children with blood.
Okay. You are mute, Sunil. You are mute. Okay.
Is it okay now? Can you hear me?
Yes.
Yeah. So it basically we look after children with blood disorders and cancers.
Yes.
And bone marrow transplant is one of the activities or the component of our services which we provide for in my department.
Okay.
So we basically look after children's. We have four components: benign hematological disorders, then malignancies, both solid and leukemias.
Yes.
And then we also do something like clinical immunology with those with immunodeficiency disorders. And then we also do bone marrow transplants. Okay. So bone marrow transplant is kind of my special interest, and other colleagues also are here, which is basically our kind of center of excellence. We do around 180 to 200 transplants every year, out of which 110 to 120 are pediatric transplants.
Wow.
And we have done about 1,500 transplants till now in the center the last 7-8 years.
Good.
Now, when it comes to bone marrow transplantation, there are few things which we need to know. One is that it's used for, as I said, malignancies, but also for non-malignant conditions. And I think you're already aware of that. There are some non-malignant conditions where it can be used.
Yeah.
In malignancies, it will be mainly leukemias.
Yes.
But there are other conditions like autologous transplants are used for neuroblastoma, sometimes for brain tumors, sometimes for Ewing sarcoma. But allogenic, which is from someone else, that is used in leukemias, myelodysplasias, and other malignancies. That is the first bit, which is the malignant disease group. Then we have got a non-malignant disease group, which is where it is non-cancerous condition, but equally sometimes fatal and equally disturbing and equally problematic. And the typical examples of that are thalassemia, sickle cell anemia, aplastic anemia, immunodeficiency disorders, and something we call as bone marrow failure syndromes, and also some of the storage disorders where bone marrow transplant can be done. These are all non-cancerous, but again, bone marrow transplant is required.
Sure.
Now, from the transplant point of view, we have two types of transplant. One is called autologous, and second is called allogenic. Now, for autologous transplant, we use patients' own stem cells.
Yes.
And these are used basically predominantly for conditions where the bone marrow is fine, but there's malignancy somewhere else. And the typical examples of that are myeloma in adults and neuroblastoma, Ewing sarcoma, brain tumors in children. So these are where autologous cells are used. You don't need a donor. The patient's own stem cells become a source of stem cells for the transplant. Now, the second one, which is allogenic, which is from someone else, is the most common one, because that has got more varied indications, as I said, leukemias and other conditions, and then all the non-malignant conditions will require allogenic transplantation. Now, for allogenic transplantation, you need to have a donor, a healthy donor. And the algorithm for that is this. So we usually, and as you already know that we need HLA typing between the patient and the family members, because there is a difference between a bone marrow transplant and a solid organ transplant like liver and kidney. Where liver and kidney transplants, you just need a bone marrow compatibility. Blood group compatibility. But in bone marrow transplants, blood group compatibility doesn't matter. You can have any blood group going into anyone. But what we need is something called as HLA typing, and that should be matched between the patient and the donor. So that would be a requirement. So first step would be to do HLA typing of the patient and the donor, and based on the HLA typing, then first thing is that we look for a family member who's a full match. So usually brothers, sisters, the chances of finding full match is higher in the blood in the sisters and brothers, which is about 25 to 30%. If you've got a one brother sister, if there are multiple siblings, then the chances, of course, increases because there are multiple siblings who can be a match. And needless to say, these need to be biological siblings. If they're from different parents, the chances of matching would be less. If they're from the same parents, biological parents, the chances would be a little higher. So first step is to check whether the brother sister is a match. If that is not the case, then we will go to the second step and see whether any other family member is a match, and that would be parents, predominantly parents, to see whether they are a match or not. If they are not a match, then we have two options. One is called as unrelated donor option. That means, is there anyone in the world, in India, abroad, anywhere in the world who's got the same HLA typing as the patient has got? And there's something called as donor registry, where you can search for these donors. And we have got multiple donor registries in various countries. We have got one in US, it's called NMDP. There's one in Germany, it's called DKMS. There's one in UK, it's called as Anthony Nolan. There are two in India. One is called Datri, one is called as BMST. So there are multiple registries in the world.
So you have access to all this? You have access
we have
to
got
all
access,
this?
Yes, I have got access to all of that. So we can search for all over the world if there's a donor for any particular patient for searching for a donor. That is, for this unrelated donor search, which I have to do, I need two things. One, I need HLA typing of the patient so that I can search for the donor. And number two, we need something called as high resolution HLA typing. So for example, the last patient which I sent me with a patient with sickle cell disease, this is a low resolution HLA typing. Low resolution HLA typing is good enough for matching siblings. If you are matching siblings, low resolution is good enough because they're coming from the same parents. And if you're coming from the same parents, if you're matching a low resolution, you'll automatically match on the high resolution. But when we're matching a patient with someone else who's not a family member, not a brother sister, then we need something called as high resolution HLA typing. And I'll send you an example of a high resolution HLA typing to see how it looks like. And low resolution. So it just give you a little bit of idea how it is different. So if I have a high resolution HLA typing, I can search for donor for any patient in all the world donor registries. Okay.
This is what I'm going to request. Okay.
Correct. Now the second is in unrelated donor registry transplants, there will be additional cost which the registry charges. Okay. And that additional cost with the registry charges depends on different registries. For example, Indian registry, which is in Datri, which is in our country, it charges around $10,000. With Germany charges around $40,000, but then for India, they have got a special discounted price, which is again $10,000. So they charge only $10,000, but if they sells to you in US, they'll charge you $40,000. But us, they charge only $10,000. And similarly, Anthony Nolan, they charge around $30,000. And then there's a US registry, they charge around $40,000. So depending on where you find the donor, which registry, there'll be a registry fees which we have to pay if there's an unrelated donor. But having said that, till this date, we as I said, we do patients from almost 50 countries. But till this date, I have failed to find a fully matched donor for anyone in Africa. Okay, I have not found a fully matched donor for any African patient till now. And the reasons are because there is no African registry, there is no registry in Africa. And number two, whatever other registries are there all over the world, the number of African donors on the registries are almost negligible. And we usually tend to match our own people. African will match African, Indian will match Indian.
Sure, we don't have, there is no registry in Africa.
Correct. But I still do that exercise. If the HLA typing is available, high resolution, I can still do that. But that's what I said. The caveat or the downside is that we don't find a match for them, unfortunately, because the number of people in the registries are not there. So that is something called as unrelated donor transplant. And if we do not have a fully matched unrelated donor transplantation, if we do not have a fully matched family donor, then we can look for something called as haploidentical transplant. That means half match. Fortunately, half match donors are available in each and every family because your parents are always half match with you. Your siblings, brothers, sisters, if they're not a full match, they may be half match with you. So practically every patient, we can find a half match donor.
Okay.
All right. And they can be donors for them. And when you do half match transplantation or a haploidentical transplantation, that is done by two different ways. Because there's a mismatch between the patient and the donor, we need to address that mismatch somehow. And that is done by two different techniques. One technique was, in fact, discovered or whatever, invented or whatever you call it, in John Hopkins in US. Yes. That's called a John Hopkins protocol. We use something called as post-transplant cyclophosphamide as a part of that. Post-transplant, you give them cyclophosphamide, a medicine, to kill the cells which are not matching. That is one technique. The second technique, which is the Germans had pioneered, we use something called as TCR alpha beta depletion. We take the cells of the donor, we use a machine called TCR alpha beta depleting machine, and we remove the cells of the donor, take the bad cells out and give the good cells to the patient. In our experience, we had the largest experience of haploidentical transplants in India for children. We had about 250 haploid transplants. In my experience, we have done about 110 of TCR alpha beta and I think 130 approximately of post-transplant cyclophosphamide or the John Hopkins one. In my experience, the TCR alpha beta transplants have done better than the John Hopkins protocol. But the problem only is, again, the cost. When you do a when you do the TCR alpha beta depleted transplantation, the kit which we get for Germany, it's Miltenia company who makes it. Again, they are giving us 50% discount on that. The original cost is around $35,000 of that kit, but they give us some $18,000, $19,000, which is again a good help, but still is a little cost for our patients and of course patients from other parts of the world as well. So that is, in brief, what are the different types of transplantations and how we do this algorithm. So first is, starting step would be HLA typing, and then we find a donor who will be a match. So that's one. The second aspect is that the patient who is getting the transplant has to be ready as well from the disease point of view when they go for the transplantation.
Yeah.
Okay.
It has to be in remission.
Someone is, for example, having leukemia. Now, leukemia has to be in good remission before they go for transplantation. And when I say good remission, there's something called as minimal residual disease, which I know, unfortunately, not a lot of African patients is not available. The test is not available. That means the bone marrow is almost clear of leukemia, and then you transplant them because the outcomes after transplant is going to be better. But at least, because I know MRD is not available in Africa, but at least their bone marrow should be in remission. So what happens sometimes, I have faced this problem in some places is that
one second, doctor. One second. Hello? Badis, do you want to join a Zoom with doctors in India? I'm now just to listen. I will get you the link, and then if you have time, just join. Okay? All right. Thanks. One second. He's gonna. This is the guy who tried to do the telethon all the time, and he's very successful all the time. He can get me what he wants. And he's in London. Copy. I'm gonna send it to him. So 1 second. I'm aware about what you are saying. I mean, all the steps, because I used to work with Duke University, where we saw a lot of patients with bone marrow transplant, and I was following them. And when they don't found, I mean, the donor, they use the cord blood and all the steps that you'll be talking. I know from the fact that they used to do this, even from Johns Hopkins. And if you are doing that, means you are a champion. I mean, I'm very impressed but what you are doing. I mean, and this is why I want to open a channel with your medical institution, even on the future. In Algeria, what they do, we have like just limited patients that can be transplanted. They don't
Yeah.
use services. They have like a service of less than 10 patients for all Algeria, and it's done only
Hmm.
in one place. And the problem is they don't, sometimes they don't do it. They don't do the transplant. They just treat through chemotherapy. They have a protocol, and they don't do that. So
Correct.
they don't have all this technicity that you have. And
Hmm.
I'm gonna. So you don't have this they don't have this technicity. What we are planning to do with Mr. Badis is to create like a type of relationship. If, for example, your institution will join, I mean, the institution in Algeria and help them
Yeah.
do that, I mean, in the future. So now,
Yeah. Yeah.
of course, we have like this patient. We hope that those four patients, they will get, to India, and we are behind them. And I know it's
Mm.
easy. I mean, so many patients may die because of the rejection of the transplant. But
Correct.
my goal now is to try to have a high resolution HLA typing, and I will try with the low resolution with family, and as much as I can, I will send it to
Yep.
you. And then if they are not a match, I will try to send the high resolution. I hope they will do it in Algeria. I'm very I don't know, but I hope they will do this test, and then we'll start finding for the donor. And then you said for the autologous, I mean, for people they can take their own cells. Do you think any patient can have this procedure done, or if they are sick? I mean, if the leukemia or they are acute.
No. So autologous transplant cannot be done for leukemias. It can be done for very select diseases where the bone marrow is okay, like multiple myeloma, neuroblastoma,
Okay,
Ewing sarcoma, brain tumor. So autologous transplant is for a very select malignancies. For
okay,
leukemias, it doesn't work. For aplastic anemia, it doesn't work. For immunodeficiencies and thalassemia, sickle cell doesn't
doesn't
work.
work.
So it is
Yeah,
only
for
for
the patient
it's
that
only
we
for
have, I don't think one will be.
none of them will have autologous transplant. None.
Okay. So what about the guy with the epidermolysis bullosa?
Yeah. So for April Boloza patient, I had seen I had seen the pictures.
Yeah,
The pictures were not too bad in the sense it's not a it's not a very severe form. So what I
okay.
wanted from you is that if it's under millimeters, if there is because it was just pictures, so we need to
Yeah,
figure
yeah,
out whether
I
the
know, I don't.
yeah. So if there's a diagnosis has been made either on the genetic testing, how they have made the diagnosis, or there is a biopsy which has been done and proven to be epidermal bullosa, because I need to be 100% sure that's epidermal bullosa before we transplant that child.
Okay. All right.
Yeah.
I will
Dr. Azadine, I am not very sure that high resolution typing they can do there. What I can do is that we can Prabhat and Guru,
Yes,
if
sir.
we can
Yes,
if
sir.
we can see whether we with MedGenome can do some tie up with them in this, they can send samples
Okay.
here through somehow, if that is possible,
Okay.
and they
Okay. Right, sir.
they run the samples here, so we may do that as a parallel activity if possible. I know
okay.
there are some
Okay, sir.
limitations of blood samples coming from abroad, but we'll see. We'll explore that option.
Right.
Do you
Right.
think
But
if we can
but
send if we can send like their blood samples? I mean,
that's what I'm trying. We'll try to figure out whether we can
yeah.
do that with our laboratory. The second is that, as I said, high resolution X-ray typing is required for finding a donor, right?
Yeah.
And the chances of finding a donor for these patients is extremely low. As I said, I have never come across any patient, and I must have dealt with more than 300 400 patients from Africa. We have never found a donor for any one of them. So I feel that if the first step of low resolution X-ray typing we are not able to find a donor, that practically means that they will have to go for a haplotransplant from one of the parents.
Upload. Okay. Okay.
So yeah, below. So I that will be the practical thing. But anyways, we'll still so you I mean what I'm trying to say that you don't need to spend a lot of energy in getting high resolution typing done because we want to look for a donor,
Okay.
because we will hardly find a donor. And but we still explore this option of if it's possible for us to get the blood sample there, that we can do. But if low resolution is done, that should be good enough. Because at least that is a quick overview of the family status. If there's a family match donor, that is a quick status we
Okay.
can know. That is number one. Second, I think you mentioned cord blood, in your discussion. We also used to do cord bloods, but we have stopped last 4 or 5 years. We have stopped doing any cord blood transplants,
Ah,
and
okay.
that has a specific reason. Because the cord blood, when you do a cord blood transplant,
50%. Yeah.
there's something called as engraftment. So engraftment
Engraftment.
is
Yes.
delayed. It's usually takes 3 to 4 weeks, and that's a problem, because the more it takes for engraftment, the more is a problem of of mortality and other things.
Yeah. High
Now
mortality
people,
rate.
high
Yes.
mortality, correct. So haplotransplants are doing better than cord blood transplants now. So hence we have stopped doing them. Haplotransplant is in our hands. For thalassemia, sickle cell is around 80 to 90%. For leukemia is around 65 to 70%. So we have stopped doing cord blood transplant for that reason, because outcomes of haplo are a little better. So we
So
don't
you
now even
have this
consider that.
this procedure that Johns Hopkins is doing, that you clean the blood before
Yes, so we have that. We have that. That's called as T cell alpha beta depletion. We have that. We have the machine.
depletion. Okay.
We have, and then we get every patient. We have to get a kit from Germany. We import it from Germany for every patient, and we do that also. We do every month 2 to 3 procedures with T cell alpha beta depletion these days.
Mm.
So it's a routine procedure for us
And
now.
then they will be under immunosuppressor for all their life, right?
No, so that's another difference between a bone marrow transplant and a solid organ transplant. Immunosuppression is only for few months post transplantation.
That's it.
Once they
Okay,
become
good.
friends with each other, we stop immunosuppression. Unlike solid organ transplant, liver, kidney, you need to have lifelong immunosuppression. But
Oh,
these
okay.
these patients, after a few months, will stop immunosuppression.
I'm very impressed about what you're doing, Dr. Guru. But Dr. Sunil, I want to have these collaborations in the future with Algeria. Will you
Sure.
institution to do that with us?
Yes. So there are now three aspects of what we are talking today. One is the immediate, patient help or patient management, which is required, which you have, shared with
Yes,
us the last few weeks.
yes,
That's absolutely fine. I think, as I said, unfortunately, I don't have a concrete plan because I don't know the X-ray typing. So if these patients can get X-ray typing done, okay. If they cannot get X-ray typing done, they can travel with the families. We can do everything here. We can do X-ray typing, matching, all that, and go ahead with the transplantation. So that
yeah.
is
It's going to take
about
time.
these patients.
Okay.
And now the second is about collaboration with the Algerian Center, and we can collaborate with them in two different ways. One is that, and this is because we have been doing it with some other centers and some other places, so that's why we already have this kind of system in place. One is that if their doctors want to, or nurses, or whosoever from their healthcare team wants to come and spend some time with us,
Yes.
what we call as international fellowships, 3 years, 6 months, 1 year, we can do that.
Excellent.
They're most welcome to come and do that. Of course, they will be honorary positions. We don't pay anyone who comes for these
Of course.
observerships, but they're most welcome to come and join us and
Excellent.
do that. So that's one. Second is, we can have a collaboration with the university there or the hospitals there, and help them to build capacities locally, which you just mentioned. So if they can build the local capacity and have the transplant facility or other facilities done at the local place, eventually that will be great. And we are happy to do that as well, to handhold them and build the capacity for them slowly. That is also possible, and we are doing that from various centers and within our country and outside the country as well. So that is also possible. So we can collaborate on these three fronts, which is absolutely fine.
Excellent. I'm so happy. And if, for example, for some reason, can we send you like this sample from blood, and then you can do it there in
So
order
that's what I
to
that's
prepare?
what I was saying, that we will check that, because in the blood sample coming from international, this thing, is something which we'll have to figure out, because there are custom clearances and other formalities at the airport and other things. So what we will do is we'll check with our laboratory tomorrow.
Okay.
We'll check with them whether they are able to do that, and if they're able to do that, then we can receive the samples for doing HLA typing. Then it becomes very simple. Then that's not a problem.
Excellent, Dr. Tub. Excellent. Thank you so much. I mean, I know how you are doing this thing. I mean, it's the same as the United States. They do the same thing. I mean, nothing different. And I hope all these patients to come to you. And one day I will come to your center to visit and try to reinforce the relationship.
You're most welcome, Dr. Azrin, anytime.
Thank you so much. Thank you so much.
Great.
Guru
So anything else you want to discuss with us?
Yes, I mean, just you just said what you have to say. I mean, for me, I'm confident that those patients can receive the best treatment in your place. And Guru last time he was showing me the patients where they can stay not far from the hospital, and he shows some pictures.
Yes, Tamboli, we were referring to the service apartments which are nearby to the hospital.
Yeah.
They can stay for example, it will be charged on month-wise. For example, like maximum of say $250 per month they can stay. It will be very economical. Do not worry about that. All the logistics support we'll provide you. And clinical support, of course, our expert, Dr. Sumil Bhat, will be providing you. And we are there with you. We invite you, and we will send you all the testimonials of the patients that has been treated at our center. That we will be sending you tomorrow.
Send me like pictures and all
sure,
the.
Sir. Sure, sir.
All the pictures, testimonials, the literatures, whatever is related to the bone marrow, we'll be sending it to you by tomorrow. You will have it in your system, and all the brochures, whatever we have, the technical specifications, we will send you. You can study that.
Okay.
And if you have any further clarifications on the same, we can always reconnect once again, maybe a couple of days later. Once after you receive, you'll obviously have some doubts. So we can once again connect maybe on Friday once again to recap on where we are. Is that okay, Stamboli?
Yes. It's okay.
So Prabhat, it is your responsibility that we need to once again connect on Friday, same time at 8 p.m. Indian time.
Sure.
So that we recap on what we have discussed today, and then we will see how we can move forward.
Sure, sir.
So Bedis, are you here?
Yes.
Did you hear? He was explaining the whole process.
Yes, I've heard. Yes, I've heard.
And exactly what they do is the same thing as they are doing here. I mean, they are doing here in the US. And they are also willing to help, I mean, those patients, if we can, get some good relationship with them, and we'll try to, they help us later on when we establish this institution.
That's what I've heard, and thank you very much. Yeah, it was great, to hear you.
Do you have any question? Do you have any question for them?
It's just about the after the thing. I think you spoke about this.
Yeah.
Is if there is some complication sometimes, after the transplant, and when the people, when these kids, they go back to the patient go back to Algeria. This is only what I'm worried about,
I mean, they stay, I think, 2 months or 3 months in India. I mean,
so that's a great question, I think, which you have asked. It's a great question, because our job, is half done by the time they get discharged from the hospital after transplantation. The job is half done. So, what we usually do is the patients who are coming from other countries or other states of our own country as well. If we have a good, robust system locally, we usually send them back quickly. After they get discharged from the hospital, they travel back to their country. For example, Oman. If we see a patient from Oman, they get discharged from the hospital and go directly to their country, because we know their system. University of Sultan Qaboos University is capable of looking after that. But places like Nigeria, for example, or Zimbabwe or Mozambique, where patients come from, or even from some other countries, from UAE. I see a lot of patients from Dubai and Abu Dhabi and all that. Although they are rich countries, but we know that the facilities there are not great to follow them up after transplantation. So that's why even after discharge from the hospital, we usually keep them with us for around a couple of months post-transplant. So they have to be ready to be in India for almost 3 to 4 months, because when they go back, there will be a problem of follow-up. So that is one. So that is something to kind of address that. But even after 2 to 3 months, when they go back to their country, it would be great if you connect us with some of the local doctors, 1 or 2 doctors who may not be particularly oncologists or hematologists. If their hematologist is great, if we do not have hematologists there, but it'll be great to connect with 1 or 2 of them, and we can be in touch with them, and kind of guide them with further, if any problems are there, or how to, follow them up, what medications to be stopped, when to be stopped, all of that we can do with them. So although we have some follow-up, what we call as plans we give to the patient, but still, the patients do not follow any mathematic calculation. They will have their own path. Every patient will have their own, what do you call that, follow-up. So we can coordinate with the local team. So if that would be done, because then we can coordinate with those people locally. But as I said, that will be great, but still, if they come here, they should be ready to be here after discharge for a couple of months, so that the immediate problems, if any, can be addressed locally, and not leave them to the team there, which may not be capable enough to handle them because of limited resources there.
It would be great,
So,
doctor.
yeah,
Dr.
yeah,
Stamboli.
Stamboli, one more point we would like to add is that going one step forward, in case if there is a willingness from your end to accept our doctors there, in fact, we can request Dr. Sumil Bhat also to travel once in a while, once in a 6 months. And Algeria is a wonderful place. It's not very far. We can travel there, reach out to those people, do a follow-up
we
kind
can
of a
bring
camp
like 2 doctors.
once
We
in
can
6
find like 2
months.
doctors to follow those kids, and they can come with them.
Yes, yes.
Okay.
Yeah, we
See,
can.
there are
We
a
can.
couple of options. Yeah, yeah. Stamboli, see, either you send your doctors here who gets trained under a doctor, but
Yes,
or the alternative way, we can even travel to your country and then see the follow-up patients and then see the next batch. So we can prepare, in fact, for the next batch of patients who can be done a small kind of a medical camp. We can see them, the future patients, and then we can handle them accordingly. Without, sir, Dr. Sunil sir, I think this I've said without your permission. I think you will accept to it.
No, that's fine, Guru. That's no problem. So that should be okay. Yeah, but still, we need some local champions, 1 or 2 doctors locally, to be able to, to be able to receive them and look after them and all that. That will be really great to have, someone local.
We can provide the Dr. Stamboli. Yes.
Yes, we can provide like at least 2 doctors to go with them. Yes, yes. Okay. Hematologist. We have Dr. Gouda.
Yes, Gouda. Yes.
And then she can bring another assistant with her, medical assistant.
Yes.
Yeah.
Okay, we'll ask her. Okay. Excellent.
Thank you very much.
Okay.
It was like very nice of you, and we keep in contact. Okay, all the time. We'll about the evolution. Okay.
Thank you very
have
much.
A follow-up meeting, Stamboli, on Friday. Is that okay?
Guru, I'm traveling on Friday, so I'll not be here. But if I am required for the meeting, then either probably Saturday we can do, or Sunday we can do.
Saturday we can do.
But if it don't require me, then it's absolutely fine. You can go ahead, no problem.
We can do it maybe in one day when after the telethon with Badis that he's gonna do for those kids.
Yes, that sounds good.
We can bring like doctors from Algeria who will be, introducing to you, and we'll see what they can do, what they cannot do, and we'll go from there. Okay.
Sure. That sounds good. Yeah.
Okay. Fine.
Great.
Amazing.
Thank you so much, Dr. Sunil, for your explanation. It was great. Mr. Prabhat, Mr. Guru,
Thank you, sir.
so much. So you are the whole, for the international Guru and Prabhat work at the international office, right?
Yes.
Yes,
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 sir.
yes.
Yes.
So you are good organized. Okay. Okay, let's
Great. It was lovely talking to you, Dr. Azadin and Dr. And Mr. Kohli. Have a
Thank you.
great day ahead, and
Thank you
we
very
will have
much.
a great night. Thank you very much.
so much.
Thank you. Thank you so
Have a
much.
great day. Have a
Great.
great
Cheers.
day.
Great.
Bye-bye.
Bye-bye. Bye.
Thank you.
Thank you. Bye-bye.
Thank
Ladies,
you.
call me
Thank you.
when you're done.
Yes. Yes.